what is the problem we're trying to solve in healthcare, or should be trying to solve, in your opinion? And do we have agreement on that in this country? Kind of a rhetorical question, but I'll ask for a volunteer.
So the Affordable Care Act, those of us who supported it and tried to implement it always said that it both would reduce costs and improve quality. And the theory was that when you get everybody into the system, costs would go down. That was criticized. I think the conventional wisdom is that the Affordable Care Act did not do too much to reduce costs. I always believed that if the insurance system were reformed, what I believe correctly, in my view, that is, if the insurance system were reformed in a way that insurance companies were forced to compete on price, they would have no other alternative but to drive costs down, but to get really tough with the providers, because if they didn't, they just wouldn't be able to make a go of it. So the answer, sorry, this is a long-winded way of answering your question, Sarah, but I don't know that we do agree on the goals. I always viewed reducing costs as the most important thing. You can argue about whether the United States, the quality of health care is as high as it should be, but I don't think that's a big problem. I just think the cost is the big problem. I don't know whether it's 17 or 18% of the GNP now, but you just can't have a system which accounts for that much of the country's wealth. So my answer, if I've got to rank what the problem is, what the problems are, my number one problem is cost.
Thank you.
So somebody who supported the Affordable Care Act, and on the ground, interesting, you're right, I don't think we have an agreement, because on the ground, the problem that we were trying to solve for was apparently access, right? And so thinking about who actually has access to health. But I think the question also was, what kind of access? And so I think that was actually something, like, it's not just access. Just because you have access to healthcare doesn't necessarily mean you're going to get healthcare. And on the ground, it's a really big, interesting aspect. And then what kind of access? Are you needing in health access to social services? Are you needing access to housing? Are you needing access to food? And all of those things are attached to health. And I think I read somewhere about how comparing the United States to, like, say, the English system or France system, and if you actually looked at their costs of healthcare, it was actually really low. But if you added in their social services, it actually was comparable to the United States. And why that's really important is because the shift of that cost piece was actually, is all of a sudden, it's like it's in equal proprietary. But in the United States, we think about cost based off of a hospitalization, or the cost of how many days they're staying in a hospital, in the bed, and it's a medical issue when really it's actually not. So I think you're right. The question is, are we all in agreement to what that question is, what's the problem we're trying to solve? From the ground, we fought for access,
So I would start with, do we even understand the ecosystem before we really define what we're trying to solve, right? So compared to where you come from the different ends of the spectrum, what role you play, what you're trying to solve actually differs, and what means to you in the role that you're playing in that healthcare ecosystem. As you said, you hit on access, Jay talked about costs, someone is going to talk about affordability, someone is going to talk about competition, someone is going to talk about choice, someone is going to talk about reimbursements. Unless we understand the ecosystem of how it works and what it means to the different people who fall into the different segments and how everything gets connected together, defining what we're trying to solve for is like a wide range of spectrum, and I think that's what we did. We helped build the Rhode Island State Exchange, We tried to hit on those 3 or 4 parameters, which really requires the connection of connecting just not the policy or just not the offerings from an insurance plan standpoint, but also looking at consumer experience and enabling them to make a choice. And we tried all different 4 or 5 parameters. And in all fairness, since it's a small state, it's an easy thing to, I shouldn't say easy, she's gonna say no, but it's a small, I'll still say it's a small state to really, sorry, I come from Massachusetts, I get to say that. But you can try out different ways of connecting the 4 or 5 pieces, but again, does everyone in the different areas of what they belong to, whether it's politics or the system itself, do we really have clarity on what it looks like and what we're trying to solve? And only once you get there is when you can clearly define or actually define a path that can help solve these 4 or 5 big hits of cost, access, affordability over there.
The answer is no. We're unlikely to have it in the near future. And so therefore, we have to take an approach that takes that into account.
There was mention of cost, competition, access, affordability, choice, but no one said better health. And I guess, Jay, maybe when you talk about quality, there's a little bit of that, I think quality is, I think there's a lot of people out there who believe in, I call her like the magical quality fairy that like just kind of sprinkles quality all over our healthcare system, but people aren't kind of focus on like what that really means. And so anyways, quality health outcomes, I would maybe perhaps add to the list of problems we could try to solve. So let me get to this this question of the Affordable Care Act, because obviously all of you were involved in implementing it in one way or another. And so talk to me about what was unique about the Affordable Care Act in terms of the role of government versus the role of the private sector, or if there was something unique, was it in some ways kind of an attempt to create like a different business model for health insurance, in which the government was not only setting up a market but also selling the products on that market, and yes or no? What did we learn from that experience of that intersection of public and private?
I want to hear your answer first, and then I'll give mine.
Okay. Yeah, and I'll try to be less long-winded. Well, what we learned is, for better or worse, the government, or anyway, the Obama administration, fortunes were tied in with those of the insurance companies because of the way it was structured. The administration had a stake in the success of the insurance industry, and I mean, you can argue that's good, but in a lot of ways it's bad. The government's no longer completely neutral with respect to the industry, and is not really an enforcer with respect to the industry. They're a partner. And at HHS, we love to talk about partners, but I'm not so sure it's such a good thing to be partners with the industry. Anyway, for better or worse, that's the system we came up with. One in which the private carriers are, it's not, the government's not in the insurance business, the private carriers are, but the government is in the business of trying to get the private carriers to succeed.
There you go.
In Rhode Island, the way that we implemented that, the bill was around the concept of a business in government. And I will tell you, it was excruciatingly difficult to do it. We had an investor. The investor was the federal government. From my perspective, we owed the investor a return, right? And the return could come in a variety of different ways. One is lower cost, better quality, more competition, more entities in the market, and hopefully over time, money back. but the concept of that, of trying to do a business, and this is the thing I've tried to wrap my head around in the conference that we've had, and why when I said yes, I would do this, I came to the whole thing so that I could understand what the message was, right? So in this case, it was a business trying to do a startup in a government setting without any clarity on virtually anything. Structure, money flow, accountability, all of those things. And the barriers and the difficulty in doing that is significant. Now, what Eric is talking about here, I think is almost the flip side, I think, of business being started and then inculcated or used or substituting for a function. And this would have been a great opportunity to experiment with 5 or 6 or 10 different models across the country. But the problem was, from the administration's perspective, we passed a bill that couldn't be fixed because of the politics. And so the implementation of it had to be done from a very delicate perspective politically. And so that range of experiments at the state level with different models never happened. And in fact, what we ended up with only 13, or I can't remember how many, 13 state exchanges, which nobody imagined that would be the case, right? I mean, you didn't imagine that at the beginning, did
Yes.
you?
Yeah, I mean.
Did you think 13?
I thought it would be about a third. Yeah, this is a sidelight. No, but at HHS, everybody was always telling each other, oh, the states are going to enact their own. And they never did. And one of the mistakes we made is we never planned from the beginning to have a federal exchange throughout the country. And if a state happens to do it, fine. But we were cheerleaders for the states, but the states didn't want to be cheered for.
Right, no, and it wasn't that the states didn't want to be cheered for, it was that the politics of the governors overcame what would have otherwise happened. And I think that fundamentally changed the dynamic of the whole thing. And that's gotten us to the point that we're at today. It has nothing to do with what's happening on the ground. It has nothing to do with access. It has nothing to do with reality. It is a political fiction that we're debating over. And the ability to understand the landscape on anybody's part it's almost like you can't even have a conversation. It is an insane situation.
Yeah, so to your question, right, which was what was the attempt of the ACA and what was the attempt? So yes, this right here, right, forgot the piece of what the attempt of the ACA was, which is a humanistic piece to that, right? So here's the thing, is that the way I looked at the attempt of the ACA was to have what I really believe was the philosophy of the ACA, which is what we actually, so I'm part of an organization also called Doctors for America, and one of the things that we actually really pushed for was the humanistic piece to this, right? The ACA allowed for the push of being able to make sure that people who had pre-existing conditions would no longer be faulted for having pre-existing conditions, right? Pregnant women would not be looked at as a pre-existing condition, or having an allergy wouldn't be that way. I mean, we use talking points based off of that attempt, to me, was in the good of that administration to actually put forth. I do think that it's really important that there is a relationship and a partnership between insurance companies and the government. And the reason is because the delivery of our care in this country is the insurance companies. Whether some of us like it or not, it doesn't matter. The point is that is the actual delivery. That's the everyday life of everyday person. All of us on this panel and everybody that I take care of, I mean, it's just everybody in this room, right? And so that relationship is super important, and they have to play in the same sandbox. And the reason is because that's our reality. And so the attempt of the ACA, and I think for the administration or just us on the grounds wanting the ACA to pass and wanting the ACA to be a part of this was to be able to say, hold a little accountability in the same sandbox. So whether there's an accountability in the government, whether there's accountability in the insurance company, that partnership needed that accountability. And there was. It actually helped us start that conversation and actually implement that conversation. Whether it was good or not good, it actually did help.
And thank you. I think it's also just kind of worth pointing out that this model of, you know, the government like financing and setting some of the rules and the private sector implementing wasn't new with ACA. It was just maybe a little newer with individual market. I mean, you have in Medicare, you have Medicare Advantage plans, and there was back in the, I don't know, was it the 80s or 90s when Medicare Plus Choice kind of started, where there was like an
And there's Medicaid managed
and
care.
then there's Medicaid managed care, which is probably like the vast majority of care delivered to at least, you know, the healthy, you know, moms and babies population, and increasingly to the more complex needs populations within the Medicaid program is all being done through private companies. So this interplay is critical. Dharma.
It's always easy to look back 3 or 4 years and dissect what was right and what was wrong. But according to me, there was a huge, if I use private terms, there was a venture capitalist investment which was significant. Did the blueprint for building out the house was complete before they started construction? The answer is no. So if you left the 20 or 30% blueprint not mapped out the right way, then it translated to everyone's interpretation on what that could be and what that could entail. And it depends on every state that we picked up. And to Jay's point, I don't think federal exchange was even part of the roadmap at the first place. Now, if you put the politics into the equation, and if everyone is not picking up, and you really want this to work, now you have to find, I call it the turnaround solution that can still provide the same. And then the focus shifts to how do we help enable do that. Meanwhile, you got the 13 or 14 states who are actually looking at none of these states where, if you really understand the way their infrastructure or the systems work, most of them have been mostly outdated, according to me, at least 20, 30 years. Everyone did a revamp of their whole or part of their infrastructure, leveraging the same venture capitalist investment on the umbrella called ACA. And we extended that, to answer your question on the public and private mix. The key of the equation was, yes, you can integrate or bring a private sector mix into the equation. We did run the Rhode Island one more like a product company in that particular group. And trust me when I tell you, I've done all the Excel spreadsheets on return on investment of what investment is coming in from the federal government and how do we generate revenue by year 2 and year 3 so that it's operationally sustainable. Because in this state, the way the politics happened, you're just part of a state agency. You're really not getting the green path to either become a nonprofit or et cetera, et cetera. We couldn't set it up. And they don't want to allocate budget to fund this anymore. That politics was going on as well. So we had to come up with ways as to how can this generate money by itself without taxing the end consumers from an insurance plan standpoint. How can we leverage the investment that we had and the infrastructure that we created and the tools that we built, and how can we relicense them and how can we resell to really generate revenue so that it can be operationally sustainable. Now, that in state government, unless it's very rare, I haven't seen that. I don't know whether it happens in the federal government or not, but there is a way to meld it, and you can combine those pieces and do it. But can you put stop breakers, and did you get the right set of people convinced? And this was the same conversation from yesterday, where we're saying, unless you can explain what you're doing in a value proposition to what it means to me, if I may say so, me, from the viewpoint and the ecosystem that I come from, I'm not going to listen to how much are you going to tell me, right? So there is a way to meld it. Now, too many good brains can even actually do it better, but that's more of a pilot, and again, she's going to kick me because I say it's a small state. I kept saying that if this was done by 3 or 4 states at the same time, that's probably a model that can be expanded and replicated across both state and federal lines.
I work in the spectrum of capitation. And, and what I love about that is because it gives us the freedom to come up with innovations of what it is that we can do through the lens of the person that we're taking care of.
So in other words, rather than say the payer, whether that be Medicare or an insurance company, saying, okay, like we're gonna pay you, the doctor, for this menu of things, and you can do this menu of things, but not that thing.
Right.
Instead of that fee for service, capitation is like, all right, you're gonna get basically a set payment to take care of this person.
Right.
And do what you gotta do.
Right.
Right?
Do what you got to do to decrease the cost of that person going to hospital. So I'll give a great example. I was just talking to a table of folks, where I had a patient who really literally, she had what we call postpartum psychosis. That's the medical issue, right? The medical issue was that she had a baby, she had a psychotic episode post her baby, she had all of her children taken away from her. And she got labeled paranoid schizophrenic, which means that she's got labeled that she has a mental disease for the rest of her life, but she's never had this before, never was in a hospital. And the thing was, now she's going to a hospital all the time because what she was really distraught by wasn't this postpartum psychosis, the medical disease, right? She was distraught by the fact that her children were taken away from her, right? So the thing is, in capitation, as a doc, when I see her, she was this destroyed young woman. Every month she's going to the hospital. My charge is how to get her to not go to a hospital. So that's the money side, if you will, right? So my charge is to not get her to go to hospital, and I find out that the one thing that's stopping her from going to the hospital, like she has to show up at court to get her children back. And the thing is, the state says you need a psychiatric evaluation. That's the one thing that you're going to be able to get, like you need to determine if you get your children back, which will stop her from going to the hospital if she got her children back. Okay, so the thing is, the state doesn't provide this mandate. They don't provide the service to get her the evaluation to that mandate that was given upon her. She's poor. She doesn't know how to navigate the system. She can't have the conversation about the politics, right? She's not. And she's going to a hospital all the time. And my charge again is to decrease her hospitalizations. The one thing that stopped her was to get her children back, to go to court, was to get this evaluation. So in capitation, I was able to say to my company, hey, man, let's invest $300 to actually get her this evaluation to see if she can get her children back, see if she's competent to, right? And fee for service, I would have never been able to do that. In complex case management and capitation, I was able to actually do that. My company is so pro in thinking about, because at the end, if you really want to talk about the return of investment here, is that the $300 of upstream investment saved them thousands of dollars on the downstream because I provided a psychiatric evaluation for her. She got her kids back, never showed up in the hospital again. And she sees me. Now, one could argue that that's not a medical issue. Actually, I would argue that's a hugely medical issue. The lens of how I actually are able to take care of her medical issue was through the lens of a legal service, right? That's a medical issue. That's a health issue. So when you talk about better outcomes of health, right, we skirted around that. What is health? How are we defining health? We're not defining the health as just the absence of disease. We're defining health as where people work, live, and play and pray. That's health, right? The factor that I could talk about obesity all day long for kids who are obese, but they don't have a safe neighborhood to play in. They don't have green space to play in. So they got concrete jungle. That's their jungle. So the thing is that to me, the health investment is actually creating a park. Take away the crime, right? That to me is a health issue. So if we don't look at health in all policy, and if we don't think about the fact that every single thing that we do is a health issue, And politics doesn't think about it that way, and we keep running in our silos, and the government doesn't think it that way, and the private sector, public sector doesn't think it that way, then we're not going to be able to solve the problem. And to be honest with you, I think there's a bunch of solutions on the table. We just don't have this all the time. And you don't, and my patient, that 27-year-old's voice gets lost in the sauce.
The dominant insurer in Rhode Island lost 60% of their market because we did not do auto enrollment. We were the only state in the country that didn't do auto enrollment, and because the idea was the one entity at the table that's not at the table is consumers. And the reason they're not there is because nobody gives them the information and support that they need to make decent decisions. So we overinvested in that piece, and I didn't sleep for 6 months, but it ended up we got more return than the federal government did with auto enrollment, with no auto enrollment, and I listened to those conversations at the call center as they were choosing plans, and it confirmed everything that I've always known, which is people are not stupid, but healthcare people think that people and patients are stupid. So, so one of the components that fell out of that was the idea that how the healthcare system works, all of our brilliant ideas about how to contract and how to think about different payment models and all of those things are done without any concept of how they actually end up applying on the ground level. So in a health insurance company, you've got the underwriters, you've got the disease management folks, you've got the marketers, you've got the CFO, the contracting with PBMs and drugs. You've got all of those things, and they do brilliant jobs, each of them. They have an Excel spreadsheet, and each of them does a great job, and they save money off of each line. And what ends up happening is to save $100 off of the price of a drug, they actually end up spending in medical expense $3,000, because the step therapy and all of the other pieces mean that the person actually doesn't ever use that drug, and instead they're in the emergency room with hypoglycemia and a variety of other things. So what we started was a consumer-focused application, but we ended up with one focus on the insurance side, taking all of the plans and then applying those plans to what it would be if all of the experts in the room had exactly what they want, which is for the patient to do exactly what the guidelines tell them to do, to be adherent and to be a really good patient. If they have diabetes plus obesity plus dyslipidemia plus whatever, the comorbidities, right? If you did everything you were supposed to do, saw all the people you were supposed to see, with plan designs across all the Blue Cross neighborhood health plan, across the country, right? What would that actually look like? How many visits to the doctor would that be? How many visits to the specialist would that be? How many drugs would you be on? How does that look here? And then how does that compare to what all the experts think would be happening? And it doesn't bear any resemblance, I promise you. And the cost is through the roof because it doesn't take into account what reality is, right? So when you do that vertical look through everything that we've done in the system, the cost issues, the quality issues, the outcome issues, the adherence issues, the school issues, all of the things that everybody worries about, it becomes it's a common sense view. And when you look at that common sense view, you realize that unless we start looking at it from the bottom up with all the deductibles and co-payments and all the other things that are applied, and we compare that to what the medical expense is on the insurance and provider side. When you do that, then people begin to say, holy, things I'm not supposed to say, holy Toledo, it really does make sense to redesign around actual context and reality from a patient perspective. But up until now, what we do is we do things to consumers, we do things to patients. We don't believe that any of them have any ability to make a reasonable decision. Eric tells me, I hate healthcare, it's so complicated. It's complicated because there are all those parts and no one chooses to, it's not complicated. It's a beautiful thing when you look at all the financing and all that stuff. It's a beautiful thing and easily changed, but only if we take that bottom up perspective and match all the pieces. Then everybody gets a financial, then there really is a win-win-win here.
Exactly. But it's the paternalisticness, right, of every sector that you could think that hits health. It's paternalistic. We're actually trained to be paternalistic as doctors, right? We're trained to we have a stigmatizing, shaming, paternalistic system, and we are supposed to tell you. And you're right. That's exactly what happens. I would also argue that the solutions that everybody thinks is in the place that has the most, is the cost is most, right? Think about it. You want to fix everything in the hospital, right? ACOs were built based off of hospital, the readmission rates. The hospital got all of the money. Hello? How do you think that they never got readmitted? It was me in the community. You get what I'm saying? But no money is being poured into where the actual work is being done, right? And that to me also boggles my mind, right? It's like, yes, hospitals cost so much money. It's $12 for a Tylenol in a damn hospital. Like at the end of the day, but the thing is, the hospital gets all of the money, all of the money, all of the money.
So when we look at that vertical, I'm sorry, I'm going to pile on.
Yeah.
When we look at that vertical, the consumer's the first beneficiary of looking at that vertical. The second beneficiary, close second, is the actual provider. Because when you look at it from the provider perspective, you see the same thing. And I'm only going to say one other thing about this, and then I'll get off my horse. In Rhode Island, in 1995 or 6, when we were expanding Medicaid to low-income women and children who didn't qualify for welfare, or TANF, or whatever it was then, AFDC, whatever the term was. I got the federal government to require us in our waiver to report certain outcomes, which up until then hadn't really been done. And I knew that the state would never allow me to do the research to do the outcomes, so I asked the federal government to make us do it. And then of course they paid for a big chunk of it. And so I can remember my second year going up to the legislature and going through the results of the expansion. And they were absolutely dead set that they were going to cut the program because it was too much money and too many people were coming in. And so one of the things that happened in that first 18-month period was that the rate of births to moms who were on AFDC we were comparing the births of moms on commercial insurance versus the births of moms on Medicaid, pre and post, right? So, much to my shock, actually, because I didn't expect it to happen so quickly. Within 18 months, the rate of second births between women who were on our new Medicaid program and commercial insurance was virtually the same. So it went like this. There was like this huge cliff drop and then the same. So I gave this to the legislature, and I had a great chairman of the Finance Committee, Tony Pires, who let me testify this way instead of like asking me each line. And they patted me on the head because number one, I was a girl, and number two, it was public health, and number three, it was kids, you know. It's like, oh, that's really nice. But I could tell it didn't sink in. So I asked if I could take a bathroom break, and we recessed, and I asked him to bring a couple of members into the back room. And I said, do you realize what I just told you? What is your single biggest budget problem after me this year? Special education. Okay. What is the data on special education? And then they told me. And I said, what did I just tell you? You have fewer children who are going to be coming through the special education program. What's your next biggest problem? Number of people on cash assistance, welfare. Okay. And what are the things that everybody's told you about how people get off cash assistance? It's not by having more kids, right? And aren't you having a big debate about caps? I just told you you don't have to have a debate about caps anymore, because when women get the information and have consistent care, they actually don't need to be told not to have another child. They're not stupid. And the light bulbs went off. We went back in, and they asked me to say a few, never any of that, because that was very politically incorrect. Never any of that in public. That program's never been cut or really seriously at risk again. Because the understanding of what the financial piece is and what the intersection looks like, they never asked us about social services. Like, we paid for lead windows to be replaced in housing with Medicaid money. They're like, okay, do whatever you need to do, keep them out of my special education program. Right? But the point is that when you look at it from the bottom up, right, and then you kind of force those matches to happen, that's when the savings and the benefits start to come in. And it doesn't sound so pie in the sky, touchy-feely, gooey, blah, 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 public healthy, population health, all that stuff, because that makes everybody's eyes glaze over.
Right.
Right? You have to make it a business proposition. So, anyway, that's mine.
Thank you. You are all reminding me of a workshop in which I participated once, or a conversation going back to the complex needs person that said, no, people don't have complex needs. Like, they have, needs for food and water and kind of basic human needs. It's the system that's too complex, and we've made it too complex. Thank you for reminding us of the importance of kind of connecting the dots in a way that makes financial sense. So I don't know, I know we're probably running up on our time, and I don't know if we are going to do kind of a Q&A or dialogue with the audience, but I want to just maybe ask one more question, and that's, let's get to this question of the business case and investment. And how do the public and private sectors think differently about this issue, and what is it going to take to make the right kinds of investment in better health outcomes and in lower costs? Because a lot of the theme that I'm hearing here is there's a lot of kind of cutting off our nose to spite our face in healthcare. There's a lot of robbing Peter to pay Paul, if you will, and none of that's really resulting in any of the initial outcomes we talked about, lowering costs, improving access. It's just, we're staying in a very fragmented system. So what kinds of investments are needed, and how does the dialogue begin to change around this topic? And is it, I will leave aside the current political environment, but just to say, how does that start to happen? And I don't know, Dharma, if you want to start off, like how do you start investing in these opportunities that connect the dots?
I think before we talk about investing and how these two, public and private, can connect together, I think the key is to, sorry.
We just don't want anything to fall on our heads. It's a start.
I think the key is to understand what we call the prism of the healthcare ecosystem, right? So every endpoint of the particular prism is one player or the other, right? So you got the policy on the government side, you got the biopharma, you got the providers, you got the payers, and then you got the patients or consumers sitting on the top, right? Everyone has their viewpoint and what they care about, right? From a return outcome standpoint, right? We talk about the patient, we talk about health outcomes or solving their particular problem. You talk about insurance companies, it's more around utilization and risk. If you talk about biopharma, they're talking about efficacy and innovation. If you talk about provider systems, they're looking at servicing the patient and reimbursements for the service that they're providing, right? I'm just taking it at a high level. We can go detail into what are the 6 things everyone cares about. The point is, if you understand that there is a way to connect all the 5 particular pieces, and you can translate that into what it means to them on the ground, and you can show the economic flow as well as to, because again, it's money that's getting allocated into different pockets, which is coming from one purse. That's what I say, right? So at the end of the day, the patients or the consumers are the payers for whatever coverage you're talking about. Who pays on behalf of them is totally a different conversation based on what type of coverage you picked up or which market segment did you really fall into. So for me, whether you take Medicare or Medicaid, whether the government is paying for it, or whether it's on the fully insured, self-insured market, whether it's your employer who's paying a big chunk, or whether it's the individual themselves who are paying a big chunk, and there's a payer who's financing it, really does not matter. At the end of the day, it all equates to we are paying for our healthcare. Which pocket of money it flows into and how it gets transmitted into the different areas and what are the guidelines and who gets what and whole 9 yards, that's the complexity that we created over the period of time. Now, only if you understand it bottom up, to Christie's earlier point, there is a way to break it down to connect those 4 pieces and across specific market segments that you need to look at.
It finally dawned on me, the last panel that we had, what we didn't hear about in the panel discussion as much was what the investment and financing behind those ideas and what the business models actually looked like. And so the Denver project, one of the phenomenally different pieces of that is that there is, in fact, a venture capital type investment in that where the business has been built around the program, and the ability for a long-term stable, and in this case long-term is 5 years, but still a long-term stable kind of commitment, because you not only have program and budget from the city, but you also have outside private investment in that gets a return, right, on a year-to-year basis that isn't based on dollars, but it's based on bedtime in jail or beds in different. It's a when it finally sunk in sometime around 2 o'clock in the morning, I literally could not sleep, because the business model, the potential for that business model to be replicated, I've always thought that healthcare had a business model, right, that could be replicated in other things. If you put both of those together, the potential for having a third way, or I know that that's used a lot of different ways, but a different business model that kind of marries those things, that has some tremendous potential. And I do think it's probably one of the only ways we're going to crack this problem, because we're just going to go around in circles forever. And I'm going to give you all the insurance stuff that I have so you can sue the hell out of them, and then we'll do the same thing with the providers. I mean, but it's not going to solve the problem, fundamentally solve the problem.
Siloed by industry when you're building solutions.
Yeah,
It
it
has to have a
can't.
cross-connection.
And all those things that we've talked about, all those solutions that we've talked about, if they're bought one-offs by this provider system or that provider system to compete with another provider system, you know, they're not going to reach their potential. So there is a way to do this. I'm not quite sure yet what it is, but it involves a different look and a different partner in financing that is a private-public partnership, far beyond what we ever thought about as private-public.
The only thing I'd add, if I could, is that there's some idealistic doctors, obviously, on this panel. There are. And there's some idealistic hospital people, and there are even some idealistic people who work for insurers. But what government policymakers have to remember, I think, is that these people are all in business to make money. They're not in business to help people. They're not in business to improve a healthcare system. I mean, there's certain exceptions, obviously. But in general, they're there to make money. And so what the government's got to do is to structure the rules of the system so if people in the system want to make money, they have to act in ways that are going to promote a good health system. And that's a hard thing to do.
Well, so I agree with you in one way, which is that, well, the health system's business is perverse, right? We have to agree that being sick and poor is bad for business. What I'm saying is, is that being sick and poor is bad for business. Right now, fee for service, the way we get paid in medicine, just in general, not the way we get paid, but the thing is that actually incentivizing perverse outcomes. I want you to keep getting sick and keep coming back to me so you can pay me more every time you come to see me. That's what I'm saying, is that so I agree in portions of what he's saying. I totally agree. But I will also say that, you know, in order to create a solution, the business case needs to be that we are all in agreement, but that being sick and poor is bad for business. And so the thing is that health resiliency needs to be the solution that starts in government, that starts in business, and that starts in all of the places that we have. I don't think that I know it sounds idealistic, but it's actually common sense.
Use the words. I think we had this conversation about the investment, about social investment, right? You use these words like what was the word you just used?
Health resiliency.
Yeah, health resilience. Social investment. That everybody that has a money background runs as far away from those words as possible. I think what Shay's saying is everything is a business.
Yes.
You have to find the right model for people to make money.
Just one thing, and I'll shut up. There are some businesses which want people to be sick and poor, which benefit from people being sick and poor. I'm involved with the dialysis industry in a way. Dialysis companies love people who are on dialysis, and they love people who are poor and on dialysis for some technical reasons. But so that is a business that loves people to be sick and poor, and there are others like it.
Yeah, so I don't know. So here's the thing. People who go on dialysis are going to be in dialysis. They will make money. But the thing is that there is a fundamental reason why we have health care. And the thing is that cancer, chemo drugs, all of them will still always make money. People get cancer. I can't control them not getting cancer. They're going to make money. So the thing is that all I'm saying is that, but still, sick and poor is not good for business. Mm-hmm. And so I think that I think there's a conflation here, because it's like, you are going to make money in the chemo and pharma industry. You are going to make money in the health insurance industry. You are going to make money. So my whole thing is that people are afraid that their money isn't going to be as Trump-esque.
The sick and poor of the phrase which you're using is coming from the angle that you're coming from at it. What they're saying, and I'll say the same thing as well, which is, if you come at it from a different angle, and I have certain insurance market segments, I have certain drug areas or drug companies or biopharma companies who actually want that particular sick and poor population. I'll tell you why. Again, it's an underlying balance sheet equation if you look at it from a corporate world. There are certain areas, whether it's financing or whether it's a biopharma product or whether it's even a service in a system, okay, they do want poor and sick patients because they actually make more money in a net if they get poor and sick patients versus getting someone who's not a poor and sick patient.
Well,
Can I?
But where you come from changes the answer.
yeah, well, it does, and I agree with you, but I do think that the people here, the bottom up, the concept of all of that, what you're telling me is that basically the people who have, that everybody's a dollar sign. And wait, and so, but I'm just saying that here we are for the greater good. Okay, and here we are having a conversation about how can we all be in the same sandbox for the greater good.
So the bottom-up approach, to your point, this is where it's going to help. What it's going to help for the greater good. The bottom-up approaches can help segregate as to what that particular profile for that particular patient, what you call the group of sick and poor in a certain area or not, and who are not sick and poor, where we can come together from a policy and a government angle, to from a corporate perspective. What can be put in place that, to your earlier point, if we understand the profile bottom-up, what can be put in place or what solution needs to be put in place that we can come together that can help solve that particular problem.
And make money with people having healthier lives, and make money with, and
Right.
so I think we're all in
Right.
agreement where this is.
Right.
Your lens piece is actually really important,
Yep.
and I think that, but
Yep.
what we're coming together is saying, like, how do we flip the script and being able
Exactly.
to say, we're making money with people being healthier, then, like, how do we find ways to make money to make people healthier
Mm-hmm.
versus keeping people sick and poor?
How do you align this greater good with the incentives to do well? So it's like the doing good by doing well, and that's kind of what we're talking about. And I think when it comes to like insurance, you know, Dan started off talking about competition and having insurance companies kind of compete on lower costs, but you know, in some ways, I think part of going back to the Affordable Care Act, part of the impetus behind that was maybe flipping the script from how do you create a market in which instead of insurance companies making their money by basically, because the rules of the road are not set up in a conducive way, they are making their money by denying people with pre-existing conditions, by denying as much care as they can. And how do you flip that so that instead they're competing and they want to take better care of the sicker patients, they want to take better care of the sicker and poorer patients, and they're competing on how well they can do that as opposed to the other way. And that's not a moral judgment, it's like a how do you set up the rules of the road to make that work? Is that fair?
And to that point, the one thing that I think everybody should keep in mind is where are the insurance companies flocking to do business?
Medicaid.
They're flocking to Medicaid, Medicare Advantage, and large ASOs not because the profit margin is huge, but because it is stable and predictable. And they might actually be able to innovate approaches to manage to health. They're moving away from markets where cherry picking gets them a profit because it's not in the long run that profitable. So
Yep.
that's actually a good, I mean, could be one good thing that came out of this is at least now you can say what the real drivers of insurance companies appear to be.
All right, thank you all for this. This got really lively for a Sunday morning. I think we're all finally, the caffeine is kicking in. I'm gonna let Eric ask his question and then we'll wrap up.
First of all, is this working? Yeah. Well, thank you all, obviously. In the last 5 minutes or so here, you probably obviated the question I was going to ask because you've kind of pulled everything together into really what the intent of this panel was and knitted it all into the whole framework of the last 2 days, which was great. I was thinking, as I was listening, I think, well, gee, there kind of goes my question because you're more or less framing it that way, except that I think where we ended up was actually with the question as opposed to what the answer is to the question that I would hope we would get at. So I want to make a couple of comments on what you've said that hopefully end up as a question, and hand the mic back to everybody for one last quick go-round of do we have an answer to this. First of all, I have a slight correction. I actually didn't say I hate healthcare because it's complicated. I like healthcare a lot, as Sarah can tell you. What I said was that I was quoting all of the politicians I work with, that I think that, except for the few for whom healthcare is the real issue, and that it's a limited number, they're mostly interested in jobs and education, and you talk to them about healthcare policy, and their reaction is, I hate healthcare, it's complicated. None of them really want to go near it. And we now have a president of the United States who kind of, blurted that out. It turns out, it is complicated, and gee, I don't want to deal with it. And I think, I don't think the president is unique in that. Virtually everybody I deal with in elected office, that's where they're coming from, So, no, I find healthcare fascinating. It is complicated, but I don't think it's too complicated to wrap your mind around. But I think the problem is, Sarah and I have been having conversations around this issue for 15 years. And, my real problem is that I think I know, well, I don't think I know, I pretend to know more about healthcare than I actually do. It's like the old TV commercial that, I'm actually not a health policy expert. I just play one as a consultant. Sarah's the one who knew everything, and I had to hand things off to her. I just do the kind of, the fancy framing it for the client. But we've talked a lot about this over the years, and I wanted to tie in a couple of things that you said of how I've thought about this issue over the years. First of all, this notion of what you were trying to do, Christy, when you were there, and we talked about this a little bit last night, the idea of making, essentially starting a business unit within the government to do this as a business. And that's not exactly the opposite of what I'm talking about. In fact, that's the flip side that I think, is the current that needs to run through everything that we're talking about. I think that there are business models that are emerging that will have to emerge to compete with, and in some cases take the place of what have been thought of as traditional public services for at least the last 100 years, maybe not going back further than that. But the flip side of that, it's the thing with the Norwegian and Swedish postal competition. Businesses are in a competitive environment. They haven't had to think in those terms, but they are in a competitive environment. Other governments are figuring out how to poach their business. Businesses are figuring out how to poach their business. As that happens, the taxpayers, who are ultimately their consumers and their board of directors, are looking and saying, I can get better stuff elsewhere. I don't want to pay taxes anymore. It's not all just taxes, it's not all just race, all the things we think of as driving the rise of the right here, or at least the antipathy to the government. Part of it is government doesn't do a lot of things well. Most of us spend our careers around government, and we think it can be useful, but the more time you spend in government, the more you know how dysfunctional it is. So it's not surprising that consumers, / taxpayers look at government services and say, if I can get it better someplace else, I'm going to, and then I don't want to be forced to pay for it anymore. Anybody would say that. So governments need to learn to compete as businesses. And I mentioned that the term paper that I have my students do in the Future of Government class, they have two options. Most of them opt for design a business model to create a for-profit business to displace something government's currently doing. But occasionally, they'll take me up on the flip side of that, which is come up with something that the private sector is doing that you think the government can actually do better, and put together a more or less profit-making model to do that the government can do, outcompete the private sector, take the business away, and make a profit, or however you want to frame it, for the taxpayers, at least make it self-supporting. Most people think that sounds ludicrous. There are, in fact, government activities that generate a profit. The strangest example is the Postal Service clothing line, but there are things government can do to produce revenue in what it does. And secondly, there are plenty of things government can do better than the private sector. I think insurance is one of them. If you think of the backbone and app thing, if you're providing something that everybody has to be a part of, insurance is not a bad app to build off of that model. So there are things that government can do as a business, but as you described, the idea of doing that has kind of it's come and gone as far as the ACA goes. We have a new administration and a new Congress that aren't looking for how they can make the ACA work right. I've always thought they would never repeal and replace; they'll just repeal. Why they haven't repealed yet, is utterly beyond me. I don't think there's a replace coming. So let's assume that we do get to the point where we're not looking at, well, how can we make what you were trying to do in the government work right? But my question would be, in that environment where federal attempts to address health care after 10 years have finally collapsed back to the 20 years before that where they were going nowhere, in that environment, can you take the idea that you had, which is roughly akin to what we've been talking about for the whole weekend, and say there's got to be some business model for doing this. It's not brain surgery to say, gee, we can create a competitive insurance model. Could you go and start a business to do what you were going to do in the exchanges, which is essentially what I'm talking about doing that that led to this conference. So that's part one of the question. Can you do that? I think you can, but in order to do that, you then have to get to what you all were saying at the end, particularly Jay, that you have to be in a world where the incentives are different, and where the incentive isn't how can you basically screw the patient, get their money up ahead, and then deny all treatment to them, but where making money comes from actually delivering value to the patient. Which takes me to a comment that you made very early on, Manisha, that you said that you love capitation because if you've got this, you're getting a fixed amount, then you have to innovate and figure out how you're going to solve the problem. I don't know that I buy that, because in a lot of businesses, if you're getting a fixed rate to solve a problem, your goal is to get rid of the customer as cheaply as they can and not necessarily solve their problem. Your goal is to increase your profit margin. It seemed to me for a long time, and this is what Sarah and I have spent years talking about, and I think she's frustrated that I don't really know what I'm talking about. But, most things that you go into a professional to have a problem solved, you don't pay them to spend their time and not solve your problem. You pay them to solve your problem. If they're not solving your problem, you don't pay them. Why would you? Why can't we have a healthcare system where instead of where it used to be, you get paid for time and materials or something under a fee-for-service system? Well, that didn't really work out, so we decided let's do capitation, because that'll force doctors and insurance companies to make sure that they're treating patients better for amount of money. I think all that does is it means they want to reduce their costs, but not necessarily improve the quality of what the patient is getting. Is there a way, can we create a system where healthcare providers and insurers are making their money because the patient is healthier or remains healthy for as long a period of time? I think there are complications in that, but can we basically get to a system where you make your money because patients are healthy? So all that rolled together is my basic question for healthcare and then how that fits into the larger thing. And with that, I'm going to turn it over to each of you to answer all that in 30 seconds, and then we'll wrap up.
So we're going to have another hour and a half, right? So
I just want to say one thing,
Yeah.
because you talked about capitation in the last one. And so here's the thing, is that capitation can give you that. That is actually, the capitation that we do is not to do it at a cheaper aspect. It's actually to innovate in a way that actually gives us healthy outcomes. So it depends on how you look at capitation. Where are you? I'm at Caremore Health. So my point is that, but I will tell you, as somebody who actually wants to, I deliver and care, and I'm the one who actually does the care, I love that the burden is lifted off of me, that I don't have to answer in fee-for-service world over exactly how and what and where I do something, versus the fact that I can actually be creative with what is being given to me to actually do this work well, and prove that you can invest even more to actually make it even better. And so I would argue that it depends on how you want to look at capitation, but on the ground, who actually does capitation and actually gets capitation, I would argue that burden has lifted off of me. And that piece right there as a provider allows for me to actually do why I set forth to actually become a doctor. Does that make sense? So I think at the end of the day, sure, you can look at it with that sort of cynical, thank you, cynical way. But when you're the one who's actually doing that work, I got to tell you, that burden lift is a huge way of being able to push forth on a social mission with margin agenda.
thank you.
Look at the bargaining power the government has. Imagine what the government could do if they could act like Walmart when they're negotiating with providers. If they went to providers and say, you give us the price we want. If you don't, screw you. That's what Walmart does. That's what the government should do. That's what the government should do with drug companies, and with hospitals, and with doctors. And if it did that, we could really bring down the cost of the healthcare system.
Christy, parting thoughts?
So, yes and no. I don't really, I fear that, mostly because the government doesn't ever look at it from the consumer perspective either, and they have a more, so I think that there's a way of combining a couple of things, but the bottom line answer to your question, I think, could you replicate aspects of this in the private sector for the benefit of government entities or states or cities, however, that wanted to link up, and are there ways of figuring out a different back-end financing mechanism to make that happen? I believe that there are, and in the app, and I don't believe that they will repeal, replace, or repeal, or all they're going to do is screw around with pieces of it. And so at the end of the day, of the ACA, at the end of the day, we're going to be where we've always been, which is every year there's a new evolution in healthcare. So the real opportunity, I think, is to create something, and I wouldn't make it only healthcare, honestly. I would expand it to include some other things, maybe finance, maybe like I would look at it from a broader perspective. After forcing my head to wrap around some of the conversation here, it actually filled in a couple of gaps that I had. I think it is doable. I think it is possible. And I don't think you need to have a massive consensus. I think you just need to understand how to leverage whatever dysfunction there is now in the most effective way. Because there's not going to be no dysfunction. We're not getting there anytime soon.
A right group of 15 or 20 people with a combination which includes right investors, right industry, right government mix, can, with the solutions that are actually underway, with X amount of crossing the pilot phase to where we are headed to, it is doable. And if we can prove that across 5 or 6 states to even start with, I think that can be scalable to design solutions and models that can actually turn in and change the ecosystem completely. I strongly think it is doable, and it's finding the right set of that 10 or 15 people to come to the table and make it happen.